and researchers. And my name is Claire McRae. I'm a GP, so I work clinically in Edinburgh in a GP practice, and I'm also a senior clinical research fellow at the University of Edinburgh. And today we're going to be joined by Professor Colin McCarron. So he's a professor in health data science at St Andrews. He's also the co-lead of the Methodologies work stream at the NIHR CNC and has done a great deal of work in multimorbidity in MLTC research. And I'm also joined with Heather Walker, Dr. Heather Walker. So she's a kidney doctor and an early career researcher at the University of Edinburgh, and we're going to co-chair this event. So just a little bit of housekeeping. As you heard, the recording has started. So we're going to keep a copy of this that can be used later on. We're going to answer questions that come up either in the chat or in Slido. So Colin's going to present a slide with a QR code for that, and we can provide that on the chat as well. And questions, so thank you very much for all the questions that were presented in the Word document. We aim to address them all. That might not be addressed immediately today, but either offline in subsequent webinars or on the website. And then, so Colin is going to present some information first of all, and that's going to be followed by the question session, and that's going to be by Heather and I. So yeah, without further ado, Colin is going to provide us with a very interesting talk. Thank you.
Okay, so good morning, everybody, and hopefully you can see slides in front of you. As Claire said, I'm Colin McCarron. I work at the University of St Andrews. I'm going to start by wishing all the English people or anybody in England a happy St George's Day, because Google informed me that it's St George's Day today, which I didn't know. So anyway, what we're going to try and do this morning is I will speak for about 20 minutes or so. I'm going to give you a brief introduction to MLTC research and try and cover some of the key points. What we then want to do is spend the remainder of the time answering questions that you might have. So to submit a question to Slido, there's a QR code on screen just now, or there is also a web link that will take you to the site that will allow you to submit questions, which we'll then try and answer. The web address is also in the chat, so if you want to look at the chat, that will give you a link that you can follow directly. Okay, so just before we start, a little bit about what the CNC is and who we are. So the CNC was set up, which is the Cross-Infrastructure Collaboration. It was set up by NIHR to try and encourage and improve MLTC research. We've identified and recruited people from across the UK, and here's a list of people and a list of, a set of pictures. And they also include our patient and public involvement contributors. Both of them have joined us today, and I want to sort of just thank Pauline and Amanda for all the work they do, and just stress about how important it is for us that we're actually sort of being driven by what patients and the public think about MLTC research. One of our objectives is to work with patient and public partners. And the reason we want to do that is it allows us to explain as researchers what we mean by MLTC research and to get direction in what we do. But we also can learn from the public and other researchers what are the key things that we need to look at and how do we best address them. So I'm going to start with something we discussed just prior to you all joining, this idea about what is multiple long-term conditions or multimorbidity. The first thing I will say is that when you look through the slides I present today, you'll see the two terms are used interchangeably. And I will address that later on. But what we tend to use now is the Academy of Medical Sciences definition, which came out in April 2018. And it identified multimorbidity, or multiple long-term conditions, as the presence or coexistence of two or more chronic conditions. The first time the phrase multimorbidity was used was actually only about 50 years ago. It was a German family doctor, and he wrote an article about how he felt there was a new phenomena in his practice where especially elderly patients were coming, and rather than coming to see him to talk about a single condition, They were coming to talk about problems they had from the multiple conditions they had, and he termed this phrase multimorbidity. Within the UK, it probably really started to come to prominence. There had been research in the area, but it really started to come to prominence after a paper in the Lancet in 2012. It was done by a group of Scottish researchers. And what they looked at was GP records to try and identify multimorbidity in the general population. And they showed that it was very prevalent, it increased with age, and also that it increased with level of social deprivation and happened earlier in people with social deprivation. So first thing we're going to address is, why do we have the two phrases? So originally we talked about multimorbidity and comorbidity, and researchers still very commonly use those terms. NIHR explored this with patients in the public, and previously they had started to use multiple long-term conditions hyphen multimorbidity because they felt that was more appropriate and people understood that better. But they had feedback from the general public, and they said they didn't really understand it and didn't really like those two terms. So since about 2020, NIHR has moved towards using multiple long-term conditions, or MLTC. It should be stressed, though, that if you look at the international sort of arena, multimorbidity is still probably the most preferred term. I will try to use MLTC through this talk because this is an NIHR event, but the chances are I'll slip into multimorbidity every so often, so my apologies for that. One of the other difficulties we have, though, is when people talk about MLTC, we talk about lots of slightly different things. So it is worth always checking, if you're reading academic information about MLTC, what do they mean? So I've used the term complex MLTC in the past, and for me all that meant was it's a group of people who've got 4 or more different long-term conditions, and that's how we defined it. Other people will define complex MLTC as multiple conditions, but that are related to different body systems. And again, other people will call that discordant MLTC. We also have this idea of concordant MLTC or cluster-based MLTC, and that's where we're talking about people who have a group of conditions where they cluster together. So things like cardiovascular disease, heart diseases, and diabetes, or another common group is people with substance misuse. Very commonly also have mental health disorder conditions. So, you know, there's all these different things that we talk about. So one of the things that we're not very good at as academics is sticking to a definition. We all like to sort of flavor it to mean exactly what we want, but it's something to be aware of when you're reading about MLTC and especially MLTC research. Of course, for most individuals, what they mean by MLTC is, do I have 2 conditions? And I think if you think about it by yourselves, many of you will be able to sit and think, yes, I have 2 conditions. Again, I've mentioned very briefly the idea of comorbidity. So again, just wanted to deal with that because again, when it comes to research, it's quite an important point. When we talk about comorbidity, it immediately means that there's one condition that we have a greater interest in. So we have what we would call the index disease, and we're interested in a group of patients who have that disease, or we're interested in people who develop that disease. We might also be interested in other diseases that they have. So the first time I did any work in this field was actually my PhD just over 20 years ago. And I was interested in adherence to medication following a diagnosis of breast cancer. And I wanted to know about survival. So while I was really interested in breast cancer, obviously if those individual women had different conditions, that had an impact on their survival. So I used the idea of their comorbidity or their comorbid conditions to help me understand better what I was looking at in terms of breast cancer outcomes. With multimorbidity or MLTC, what we're actually interested in is the patient as a whole. We don't look at them in a condition-specific way. We think about the patient and all the conditions they have. There's none of those conditions take primacy. Okay, so again then, how do we actually measure? So as I said, as an individual, you know, we can sit and say, do you have 2 or more conditions? We have now sort of settled, I think pretty much, there's still a lot of, you know, still a lot of people use different versions of the same definition or slightly different terms. But this idea about 2 or more conditions seem to now be prevalent, and that's what people will look at. This is a piece of work that we did where we were interested in how do people actually measure multimorbidity, and we identified 566 papers that reported on that. And what we found, there were multiple different ways, and it's actually really important how you measure multiple long-term conditions. So what tends to happen is it all depends on how you get access to your data. So this is an example of how we would get data for a project that we're doing around MLTC in Scotland, which led out of the University of Birmingham. And what we're looking at is we know that as individuals access the health service, records are generated, whether that's a pharmacy, whether it's a hospital, whether it's a general practice. We then have trusted research environments who collate this data and make it available to research. We're only allowed access to the data for the specific purposes of our research, and we're only given the data that's relevant to our research. But that then allows us to identify, here's the base records of where we want to look at. And partly part of what those records are, where they come from, can influence how you look at MLTC. And again, that's important. I'll mention that again in a few slides' time. What then happens is you start to look at the conditions you're interested in, and this is where measurement really matters. So what I've shown here is this is all in exactly the same data set, and what we've looked at are 4 different ways to try and measure multimorbidity. So the first one is the Charlson Index, and it was developed back in the 80s. The second one's the Elixhauser Index, and it's been around for about 20 years as well. Project we worked on, we wanted to look at specific conditions, so we worked with patients in the public to identify conditions of interest, and we looked for those. And the last one was a follow-on from the paper I mentioned earlier, where we did a Delphi exercise and identified a set of conditions we thought were really important. And if you look at the 2 graphs, you can see that depending on how you decide to measure multimorbidity, you see a different group of people, or a different proportion of people, sorry, I should say, that either have 2 conditions or 4 conditions. Again, one of the things I mentioned earlier was we know that multimorbidity, MLTC, increases with age. It's present the whole way through the life course, but it increases with age. And again, just looking at that measurement again, what we also see is that each of the ways of measuring identifies slightly different groups of patients. So for those 4 different ways of measuring multiple long-term conditions, each individual is only about 50% of all individuals are present in all 4. So this map here is saying how much overlap is there between the different sort of measures in the group of people who are identified by any one of those 4 ways as having MLTC. So again, when you're looking at this, you need to think about what do they actually mean by MLTC, how did they measure it, and what does that tell us? Okay, so again, just to show, so this was the data that I was talking about from Tayside and Fife in Scotland for this NIHR project. So we identified about 1 in 5 patients, 1 in 5 adults had multimorbidity, and about 1 in 12 adults had what we call complex multimorbidity, so 4 or more conditions. There's not much difference between males and females, slightly more prevalent in our population than females, probably because females are living longer, so have more time to get those conditions. And you can see that as age increases, the level of MLTC increases, and across the top there, that's a marker of social deprivation. So what we see is that the people who are in the most deprived areas, who live in the most deprived areas, there's a higher proportion of people with MLTC. Now, one of the things I mentioned was about you need to think about the data sources. So this is some work that Claire McRae, who introduced this session, had done, and she had looked at data in Wales. And what they were interested in was how did it differ if you were able to look at primary care data linked to secondary care data, as opposed to looking at those 2 things by themselves. So in Claire's data, and again, this is all patients of all age groups, what she was showing was if you looked at hospital and primary care data, about 1 in 3 individuals had multimorbidity. Okay, so I said that multimorbidity happens more in older people, or it's more prevalent in older people, but it does affect people of all ages. So again, this is an MRC NIHR funded project that we're involved in. That's again led from the University of Birmingham, and they're interested in multimorbidity in pregnancy. So obviously the age group we looked at here, well, not obviously, the age group we looked at here was women between 16 and 45. So is it common in pregnancy? Well, what we found in our data was that about 1 in 5 women actually had long-term conditions. And again, we showed that they're more likely to have long-term conditions, came from a deprived area, if they smoked, if they were obese, and also about number of previous pregnancies. So we know that it's common. Does it cause problems? So again, work we did in Tayside and Fife suggested that women who were at MLTC at the start of the pregnancy were more likely to give birth to a preterm birth child. And that didn't matter if you looked at it by age of the mother. So if, despite the age of the mother, if they had MLTC, they were more likely to give birth to a preterm child. Or, if they came from whatever social class, again, it was associated irrespective of those two things. So we know that MLTC is common, we know that it causes problems. On a wider population level, this is data from some work we did during the pandemic. And again, what we were interested in this particular paper was who was most likely to have a hospitalization or die from COVID-19 post their second vaccine. And the graphs on the right of the screen there are simply showing what we knew about COVID. So it had a much greater impact on older people. And then we looked at other issues. And the one at the bottom there is how many other long-term conditions did the individuals have. And you'll see a very stark gradient that suggests that as the number of conditions increased, the risk of those individuals dying or being hospitalized with COVID-19, despite having vaccinations rules. And again, right at the start of the pandemic, we looked at hospitalizations in Scotland. And again, we were able to show that irrespective of death or social class, if you had multiple long-term conditions but were hospitalized with COVID-19, you were at higher risk of death. So MLTC has a huge impact on all aspects of healthcare. Again, there's evidence that if you have MLTC, you're twice as likely to use primary care services, and you're 3 times more likely to be hospitalized. So it has a huge impact on people's health. Now, one of the questions that was submitted was about the use of social care support. There's not a huge amount on this. So my co-lead on this work stream, Hajira Dan Miller at Southampton, is doing some work on this, but there's not a lot of published work on this. This is work that was done by David Henderson, who's now a researcher at the University of Edinburgh, but did this as his PhD at the University of Glasgow. And he was interested in older people, so people aged 65 plus, and whether they were getting social care. And what he was basically able to show that the more long-term conditions you had, the higher the likelihood that you were in receipt of social care. Okay, so that graph on the right-hand side is basically showing the number of, it's BNF chapter, so it relates to people's use of medication as a proxy for their MLTCs. But it's basically saying the more medications you use, and therefore his assumption was that you had more long-term conditions, the more likely you were needing to be in receipt of social care. So again, it affects people's health, it affects people's ability to live. We know from our patient and public involvement that carers play a huge role in managing and helping individuals with MLTC. But again, there's not a lot of published information about the scale of that. Okay. So if you have MLTC, what does it mean? So one of the things that we've interested in and we've been trying to explore in this optimal project is this idea of polypharmacy. So polypharmacy is where people have to use multiple medications. So the idea is that, if you have conditions, they need to be managed. I think the most common form of management of a clinical condition is the use of medication to sort of look after it and help you live with that condition. So what we're interested then is how many people have this idea of polypharmacy, which again, there's been lots of definitions, but the one that we've used and probably the most common one now is 5 or more medications. One of the difficulties then is it starts to give you the increase your risk of bad outcomes from using these medications. So again, there's lots of work around this idea of prescribing indicators where you're looking to say, do these individuals have a combination of medications that might potentially be harmful to them? So if you have multimorbidity or MLTCs, it's highly likely you have polypharmacy. If you have polypharmacy, it's highly likely you're at higher risk of prescribing indicators. And this is sort of the idea of how it all works. So this is somebody who has depression and starts taking a particular drug to manage that depression. It then has that drug itself as a side effect. So the patient reports that side effect to the GP. As a result of that, they then get new medication and new side effects. So the more drugs you are, the more likely you are to have these sort of ill effects happen. And that's a challenge both for the individual patient, but also for management within the healthcare systems. Again, this is some work from our optimal data set, and it's basically just showing that if you have MLTC, you're much more likely to have polypharmacy, and you're much more likely to have one of these prescribing indicators that we've identified as potentially harmful. Again, one of the other pieces of work we've done with this, it's not that easy to make out, but on the right-hand side, we're looking at variation by practice. And what we're showing there is that after you've adjusted for patient age, patient sex, patient social class, and the presence of multimorbidity, there's still actually quite large variation by practice in how many patients have polypharmacy and how many patients have these prescribing indicators. So one of the other challenges then is the burden that having MLTC places on the individual patients. And again, that's just a quote which I thought was a really nice way of explaining it, nice simple terms. And it's basically saying it's the effort required of patients to look after their health and the impact this has on their well-being. And again, you know, the more conditions you have, the more things you're expected to do. The more things you're expected to do, the more of your time it takes, and the more difficult it is to actually look after yourself. We also know, again, speaking to lots of patients, that one of the big difficulties, one of the aspects of burden is how do you navigate care? So delivery of care in the UK and pretty much everywhere else tends to be by individual specialty. This means that it can lead to fragmented contradictory care. So again, some of the idea that I was talking about medicines, someone might want to use a medicine to treat disease X, but it might then actually make disease Y much worse. So you have to think about how you do that. From a patient perspective, at its simplest, you know, if they're referred to lots of different specialists, you know, they've got to go to lots of different places in the hospital. It's unusual for those visits to have been set up so that they can do that easily. So it requires lots and lots of different visits to the hospital. And one of the other things that then happens is they don't tend to share information very well, so you can get multiple testing based on who you go and see. One of the big difficulties, again, is much of healthcare these days is evidence-based, which means it's guideline-driven, but most guidelines focus on a single condition. There are MLTC guidelines. I think NICE in the UK delivered some about 10 years ago, if I remember correctly, but they're still in their infancy, and how they're implemented is still very difficult. But there's lots of sort of hope that what we can do is change how we manage people with MLTC. So rather than this fragmented sort of going to see lots of different people at lots of different time who only think about a single condition, there's been lots of projects looking to say, can we look at a better way of looking after MLTC and the individual patient? I would say that there's not been a huge push through that into the actual widespread delivery of care. So again, it's one of the difficulties we have with research. If we have a good idea, if we can show that idea works, how do we then get the clinical workforce to take that on and start pushing that through into the everyday delivery of care? Okay, so I'm just coming towards the end. So I'm going to try and flag up what NIHR recommended for future research. Now, this originally, I think, was published about 2018, and some of these things have been done. So there have been some specific calls from NIHR to try and address this. But what they're looking to do is to try and get a better understanding. As I said, the first use of the term multimorbidity or MLTC was less than 50 years ago, just less than 50 years ago. So this is an area that's in its infancy. Research has really only picked up in the last 10 to 20 years. So again, we're still learning an awful lot about MLTC and the impact it has and how better to look after it. So we need to sort of do all this background work to get a better understanding of it. NIHR and some of the other work streams within our CNC organisation are looking to think about how better do you deliver care and how do you better support patients. But they've identified, there are problems with how we do this type of work, and that's the focus of our particular work stream. When we look at policy implications, I had a bit of a look at this, and again, I think, a lot of the policy implications for MLTC and MLTC research are quite generic. I did see an editorial that was from Chris Whitting and lots of presidents of rural colleges and chief medical officers for the developed nations. So I thought, well, they were probably slightly better qualified to think about what policy implications there are from MLTC research than I was. So I thought I would try and use this. This was a quote that they used in that editorial, which I thought actually really captures the essence of what we should be looking to do. So this was someone who gave this lecture over 100 years ago. And what he was saying was, think about caring for the individual much more than you think about specific features of the disease that an individual presents with. What they have highlighted is there's starting needs. So we've got very good at treating individual conditions, but we need to start thinking about how do we start the more generalist skills of looking after individuals as a whole. They identified medical training, both in terms of undergraduate medical training and then progression through specialties as a key area that needs to be changed. And they basically said we need an intellectual shift and rethinking how we do all these different things to actually better deal with MLTC. Okay, so the last slide but one. So hopefully from what I've said today, you'll understand that MLTC is common, maybe up to about 1 in 3 adults. It's actually more common in any single disease. So I think across all age groups, if you look at what is the most common problem and you think about MLTC, it's more prevalent in any single condition. We know it increases with age. The data suggests once you get to about 65, 2 in 3 people have MLTC. Once you're at 85, it's almost virtually ever present, 4 in 5 people have MLTC. It increases with social deprivation. And that's the case across all age groups, and we know that it starts much earlier as well. It leads to more hospitalizations, more use of medications, which in itself can cause problems, and it has treatment burden for the individuals, but higher healthcare costs. In terms of MLTC research, we're inconsistent with how we define, and we're inconsistent in how we measure. But we are still in our infancy. We're starting to get gathered around that 2 or more conditions. Prior to maybe the last 5 or 6 years, there were probably just as many papers that looked at MLTC with different numbers of conditions as the driver for this person has MLTC. But we're now starting to focus and sort of say MLTC. It is important because it allows us to better compare and contrast and to learn from other people's works. If we're looking at different things, we can't really draw comparisons. Currently, our delivery of care is not well designed to support patients with MLTC, but we are looking at ways of changing that. It will, however, require a major shift in how we teach our clinical workforce and how we organise that clinical workforce to better support patients. So I'm going to leave just these 2 references. So both of these are, well, the first one's an academic paper, but it's a nice, quite long primer on multimorbidity rather than MLTC. Again, it was in an international journal, but that's a good starting point to get an idea about all the different aspects of care. And the second is what the NIHR are hoping to do around MLTC research. So I'm going to stop there and then I think pass back to Heather and Claire. They're going to manage and help me very hopefully answer the questions that you have. Thank you very much.
Thank you, Colin. That was great, and I think a really difficult challenge to try and cover in around 20 minutes the topic and background of multiple long-term conditions, which, although on the surface seems quite simple when we say it's 2 or more long-term conditions, is actually really complicated and complex. So we're going to go into questions, and I just want to thank everybody who has posed questions in advance. We're going to try our best to cover as many of these questions today as possible, but as Claire mentioned at the start, we will be recording this webinar that will be going online, and we'll aim to cover any questions that are not covered in the webinar today, either by answering and putting them on the website, but also in the future webinars that we're holding. So there are 2 other webinars that are planned for later on in this year. The first one is on Wednesday the 4th of June, and that's looking at research methods for multiple long-term conditions, and then another webinar on Wednesday the 3rd of September looking at patient-reported outcomes in multiple long-term conditions. So it'd be great to see as many of you possible back at those webinars where we'll be covering some of the questions that have already been posed in more detail during those sessions. Claire, I don't know if you want to add anything else before we go into the questions.
No, thanks very much. That was really interesting, Colin. Really appreciate that. Just we had a note in the chat, just if possible to look at the camera so that people can see your face and be able to read your lips for people who are with reduced hearing. That would be fantastic. I think we've got quite a lot of questions from the registration. I don't know if anybody had any extra questions posted on Slido. Did you see any, Heather, that have been posted this morning? Thanks.
So the first question that has come through from the chat today is obesity counted as a long-term condition, or is this a risk factor? And I know this is a question that so the research that I'm doing at the moment in multiple long-term conditions, and there's quite a large group of us as researchers that are looking at MLTCs, and it's a question that we've debated quite a lot. Colin, I don't know if you want to address this first, and then myself and Claire can come in on it. Oh, you're muted, Colin, sorry.
Are we doing the questions from the bottom?
So I was just, that's the one that has come in from people that are on today. So we're just going to start with that one, and then I'll go back to the questions that we've added from the earlier chats.
Okay, so it's not the obesity question, sorry.
Yeah, so is it counted as a long-term condition, or would you consider it as a risk factor?
Okay, sorry, I was just checking we were working from the bottom up. Again, this is something that I've sat in rooms of academics and we've discussed for at length. So I think the 2 things that always come up are hypertension and obesity. And there seems to be a group of academics are very keen on the idea that hypertension is disease, whereas other people see it as a risk factor. And I think it very happens with obesity. I think there's more of an understanding now that obesity is a condition. And I think in the last few years, it's generally been more accepted that you can try and measure or identify people with obesity and think about it as a condition. So currently, I would say there's a bit of a shift, at least in the groups or the populations of researchers that I move in towards thinking about obesity as a condition. Heather and Claire may view that differently, but that's what I would suggest.
No, I agree that there definitely has been a shift, and I think particularly with some of the newer treatments that we're seeing for obesity, people are starting to view it differently, and not just as a risk factor, but as a long-term condition in its own right. But I think there's not consensus yet, and it's not routinely considered as a long-term condition within MLTC definitions at the moment, but I think probably is likely to change in the future.
So Claire, I was just going to say the indexes that I talked about. So very often when we're trying to measure MLTC, we use an existing index. And out of the ones that I listed there, I think the NIHR index does list obesity as a condition. And the most recent one that was generated by Marisol and Bruce Guthrie at Emory University, along with people across the UK, also treated obesity as a condition. So they're both now being picked up and measured as a condition rather than simply a risk factor.
Thanks very much. That's really, really helpful. So the next question we have is, how do we integrate CEI and PPI with research to address the issues related to MLTCs? And I think that's really core to what we're trying to do today. And I wonder if maybe this might be a useful question to ask Pauline and Amanda, because we've been working alongside them, which has been incredibly helpful for us. Pauline, do you want to maybe give us some of your experience and thoughts on this, please?
Yeah, I think we do a very good job at challenging because obviously I speak, Amanda, do chip in as well, please. But we do, I say challenge, but we challenge proactively, because I will say that both Amanda and I have lived the life of a carer. So I don't mean a paid carer, we're family carer. I've looked after my husband, and I know Amanda has. And going through that emotional caring for your loved one puts you in a very different focus of how you see and manage that individual. So where we sit, I think we sit sort of possibly one step removed from the trying to manage that emotion. So you're not living with that emotion, but you're coming into trying to manage it on behalf of others, let's say, that are still going through that emotional phase of looking after their loved ones, to then influence and understand how you can better that journey for the carer. Because that's what you become. You stop becoming a wife or a husband or a partner. You become that individual's carer and everything else that goes around it, because you still have all the other things that you have to do to manage, whether it's a home, a job, or everything else. And then often you know that there's going to be a finality to it. In multiple long-term conditions, not always, but there's a long journey. And that can be debilitating to that individual that's going through it, but also for you yourself, the carer. So yes, it's very difficult, but I think we come in and we put different perspective to it. And Colin said very carefully about the multiple long-term conditions. And I know that I am very much an advocate not to use multimorbidity, because words do matter. Morbidity says that I'm going to die. Well, I'm sorry, guys, but we're all going to die. But, you know, it's using those words and trying to give positivity to anybody that has got a long-term condition, because keeping that positivity will keep that individual going, whether it's a day, a week, a year, or an hour. That will keep them going a little bit longer and give them that life. So I hope that makes sense of what I'm saying about the long-term condition aspect of it. I'm not a doctor, but you have a different level of interest and expertise. So Amanda, do add to that.
Yeah, no, thank you, Pauline. So yeah, I mean, in my relationship with my late husband, when I first became and identified as his carer, that was how I started referring to myself. And then I got to a point where I'm like, actually, David is my husband and I am his wife. So then I would always introduce myself as David's wife and his carer, because to me, and we did keep that, we kept that, the fact that we were still husband and wife, a married couple, and that was at the heart of our relationship. And that was important for both of us, for it to feel that way. So I think, everybody's journey is going to be entirely unique to them. For me, the biggest thing that I think needs to change around multiple long-term conditions is proper recognition of carers, particularly when you care for somebody who's housebound and has dementia, and if you leave the house it causes them huge stress. Even if they know the person that's replacing you as care, it's super stressful, and professionals will come to the house for the person that's housebound, and they'll be there, and it might be a sight test, it might be a hearing test, dental check, but they will not treat the carer. So all that does is exacerbates conditions that the carer might have, might develop. And I think until a society really wants to recognise and value carers, and I would think actually including carers as a protected characteristic, so that medical professionals have a duty of care to treat them and not allow their own health to worsen while they're caring and then be a bigger burden. So I think really collectively there needs to be a shift in how we see carers, because they are managing their own multiple long-term conditions and somebody else's. So that burden for them is double, and your own health is being impacted as a result of it.
And I think you're right, Amanda, absolutely. I think one of the misnomers, if you like, is that we get mixed between carers, because there are, as you rightly say, we are family carers, but there are carers in the care sector, and so we are just amalgamated. And I think realistically there has to be that clear definition. And I don't know how we do it, but somewhere along the line there has to be a real definition of family carer. Whether they stick a badge on us or a hat on us, whatever they do, they really do have to take that recognition, because the service, the health service, the whatever service it is that comes in with multiple long-term conditions, they cannot manage without us, and we get pulled in to that over and above the wife job or the husband job, because it's not designed just for male or female, it's both ways.
I think
we do have to sort of start to put together something that says there is equal need here, but the patient to have recognition and the family carer, whether it's male or female.
Pauline, a big part needs to come from actually recognising continuing healthcare. So I cared for somebody who was severely sight impaired, had type 2 diabetes, had hearing loss, had spondylolisthesis, had Lewy body dementia, and had a stroke. And CHC declared that he did not have a primary health need and was eligible. When we had the assessment, and I said, well, he's catheterized, and they're like, well, that's, anybody can do that. And I said, well, all right, so I can walk out the house now and get Joe Bloggs off the street to come change the catheter. And they're like, no, any trained care worker, and it's an unpaid carer. We are not trained care workers, and I think we're going a little bit off track now. And I can see hands up.
It's so helpful. I think what you've answered is really important. So you provide this lived experience and this perspective, which is never to be underestimated, because it's so important. Because even as clinicians, there's so much that we just don't know, and I think that's absolutely central to the design of all of our work. And I really like this idea of challenge as well. Actually, no, we don't like that, or change it this way. And it's such an important thing. It's so valuable for us. I think just one quick point is that this is obviously very relevant to people nearing the end of life, but MLTC is so relevant earlier on in the life course as well, where it has a different impact. And that's another thing that makes it incredibly complicated, but it doesn't always mean nearing the end of life, which is where it comes back, Pauline, to getting the naming correct. So I think Alan Griffiths, you've got your hand up. We'd be very grateful to hear your question or your point of view. Thank you.
Yeah, if that's okay. And I just don't want to knock what the two ladies have just been saying. I'm a family carer myself, parent carer. I have a son with a severe learning disability, autism, epilepsy. Thank you. That was the wife, and more. But I'm involved in a couple of projects with the Arc Northwest Coast. One of them is an AI project where we're looking at trying to make things easier for pharmacists and doctors to do proper, to be able to look properly at all the medication that you're on for people with polypharmacy who've got, I mean, I'm on 19, I think it is, different drugs. If you're on 10, that's 3.3 million different, combinations. Thank you. I'm sorry, I'm forgetting. My memory is going. But one thing that we've been talking about lately at Arc Northwest Coast is person-centered care. If you've got multiple long-term conditions, your GP will refer you to a different consultant for each of those conditions. So if you've got two, you go to two different GPs, maybe you're in different hospitals. If you've got three, it's three, four, it's four, etc. They don't work as a team, they work individually. Your GP can't manage all that. So we need to be thinking about some sort of care coordination that doesn't exist at the moment in the NHS, and I think that is the number one thing that we need to address going forward.
Thanks very much, Alan. That's incredibly useful, and I think that is something that we're trying to focus on. But it's really great to hear that kind of prioritised. Very helpful to hear your experience. I think
Sorry, maybe just a comment on that from Alan.
Yep.
So there are a number of projects, Alan, so I think it's probably the DynaRix project you're involved with, if I've got the projects correctly. But the NIHR has funded a number of projects, and one of the things they're looking to do is try and take the burden of how you provide that care away from individual consultants to try and start using the records that exist in people. So there's this idea about trying to provide better data-driven care, but it's still in its infancy. There's lots of things we can do. There's lots of really exciting projects, but it's trying to get them into practice where it's actually going to change what actually happens to individuals on the ground. I think is probably the biggest challenge. But again, there are funding streams that are starting to look at that. So how do we actually make better use of information and actually then do something better with it?
Thanks very much, Colin. So
if I can just come back there very quickly, DynaRix is the project I was talking about, the AI project, yeah.
Thank you. Thanks so much. So we just had a question from Nahid to hear. I think she couldn't.
Couldn't find the comment. Thank you very much. Yeah, I mean, we're talking about multiple long-term conditions, and like a couple of the previous speakers, I'm also a carer. I have multiple long-term conditions myself, and I look after my daughter. And what my vision is that obviously this needs to be dealt with at the source. What a lot of people don't understand is that you don't necessarily start off with multiple long-term conditions. They are developed as you're going along. With my daughter, yes, she may have had, one thing, but it's the medications and the other conditions that have, or maybe even one condition that has led her to have multiple long-term conditions. And I can say that for myself as well, that, it's because of one thing that another thing has developed, and so forth and so forth. And I think this is what we need to prioritize, that we do need to look from the beginning. We need to work from the ground up with patients, and not a case of when they've got all these long-term conditions, then we're looking and we're adding even more things, and then you're making things even worse. It's just like, in the presentation you were talking about women who are pregnant, diabetes and preeclampsia. There's a lot of these things that come during pregnancy. They may not necessarily stay, but at the same time, some do stay. And I think it's finding that and managing those things at the beginning. I know with my daughter, because she's got loads of these things, a lot of them then when she's put on more medication, which she has recently. She's developed even more conditions, and then you're adding even more medication to fix that condition, which again then is adding, so it seems to me as if it's just endless, and it's not the when we need to look at the source of the problem. I beg to differ with Alan, because our GP is very good, very cooperative, and I do believe that GPs do have a very diverse and a very wide range of knowledge. We're actually very unique in that sense, that we go to our GP and they can direct us to certain things. The problem I do have, and I agree with Alan, that we do need a one place where all this is connected. It's the team that we need that are looking, we can't just go to hematology and they just look at your blood and something else could be wrong, and they're ignorant of that and they just look at their condition. We do need to look at the person as a whole and their conditions as a whole, rather than this is just multiple lung conditions that only so and so doctor can look at. But we do need to, it's a map really, and we need to look at it all together, not just one thing.
So again, I didn't actually comment on what causes MLTC, because it's what causes individual conditions, but there's then that complexity comes in, and the primer I recommended does actually go through what they think could potentially be causes, or how do you think about the causes. And just as you mentioned, one of the things they do talk about is medication use, because they're saying that use of medication to manage one condition can exacerbate something else or create something else, which then needs a lead. So there is that sort of complexity about it's not just as simple as this causes one condition, so avoid that. Some things have common determinants, but other things it's a lot more complex. So there is a big issue around that, and a whole sort of need for better understanding about that.
Great, thank you very much. There's some really useful points. Tessa, I think you had your hand up for a while. Would you like to come in?
I'll try and keep it brief. Someone's about to ring my doorbell. I've been working with respiratory for about 15 years, exploring a lot going on. Mira, can you answer the door, please? And sorry. And basically, I fully accept, for example, learning disabilities. They smoke a lot. Respiratory care is never looked at. They focus on the learning difficulties. So we're separated. Everything is separated, as we say. The next step, that's fully accepted, is the handover. The handover of if I'm in hospital being treated for something, the GP doesn't know about it until the hospital has finished the care. Now, there's a gap there. There's a gap. So if there's a centralized place to look at everything, you can't be waiting for the results of a 6-month visitation for that team to hand over back to the central point. So to actually put support into practice has a hiccup. Thank you. Ask him in, please. Thank you. So there is a point there to actually how we're going to put it into practice, how it's going to be managed, because at the moment, as we're saying, it's broken up all over the place. And that's my experience. I'm going to have to go. I've got a chimney sweep here, but
Tessa, you're on mute.
Can we have the NIH, thank you, reading link put into the chat so we can access it? Thank you. It's the Collins reading link on the last slide. Thank you very much. Thank you. Great
Tessa.
meeting.
Wonderful. Thank you very much. Brilliant. So we've got another, I just think maybe we could answer a couple more questions. A really interesting point from Samina is that the local ICB has funded care coordinators and GP surgeries to help coordinate, and that's been a useful, or has regular 6-monthly reviews. So it'd be interesting to see what the experience of that is and if that's something that should be rolled out it sounds like the sort of thing that would be very helpful. And then I think Alan Griffiths has pointed out there's some work on clusters as well. I think we're going to talk a little bit about some of the methods that are used in multimorbidity in MLTC research, looking at that aspect. I think in the chat we've got a question that's come up. MLTC means having 2 or more conditions, but people can have very different types and levels of problems. Is there a better way to group and describe them? I think, Colin, you're in a very good position to answer that one.
Yeah, and again, it's one of the issues. So MLTC, as it stands, is probably a useful concept. So, I have MLTC. I've got various conditions that mean I have MLTC, but have they a huge impact on my life? Well, one of them is I'm deaf, so yes, they do. But I would never think of myself as having MLTC. I think where we need to look at is how can you start identifying groups of people with MLTC where you can actually change services. And Alan mentioned clusters. Claire's just mentioned we're going to discuss it on one of the future seminars. But it's that challenge of trying to identify a group of patients who have enough commonality in the MLTC they suffer from, where you can actually think about an intervention. And again, I think that's one of the big challenges. So MLTC is a nice concept, but as a mechanism for actually delivering care, it's very difficult. So somebody with hypertension and asthma has a very different need and a very different sort of set of how they manage their conditions, how their conditions are managed by the health service than somebody with COPD and heart failure. So it's that thing about how do we actually best identify groups of MLTC patients to better provide services for them. I think Claire and Heather, you might want to comment on that because I know both your work's been around that.
Yeah, I think the only other thing I was going to say is that somebody's also highlighted in the questions about mental health conditions and are they included in definitions of MLTCs? And I think it's important that we acknowledge that they are, and that's another important thing that people have looked at is not just MLTC by number of conditions, but there are different definitions that people have also looked at that Colin's referring to here as clusters. So people that have got mixed mental health problems alongside physical health problems, and so exploring some of these different combinations has also been part of or is now contributing to be more research in the MLTC field.
So again, that's a really good point. So originally MLTC, people very much focused on physical health conditions, but there is now much more work about the impact of mental health and mental health ultimate MLTC. Again, just on Heather's point there, I think mental health is a much bigger problem in the younger groups of people. So when you look at MLTC across different age groups, what you find is that in the younger groups of people, it tends to be a higher preponderance of MLTC caused by mental health. So it is that thing about, different conditions impacting different people at different times in their life. And the type of MLTC that people have is also very different depending on the time of their life that they're at.
Yeah, and Cheryl Blake's also commented trauma and how it's connected to the somatic system and in turn causing multiple long-term conditions. And there's also a question about adverse childhood events and the link with multiple long-term conditions, and both of those are important points. And I think bringing back to what Nahid was talking about how a lot of this can start early on in childhood, and it's not just about looking at long-term conditions in older populations, but at the things that can happen very early on in people's life course and how that can impact on people developing long-term conditions and the outcomes that they can have. So yeah, I think that's also a really important point.
Brilliant. I think we should thank you very much to everybody, to Colin and everybody who's come, to Amanda and to Pauline as our PPR partners. It's really interesting to hear everybody's questions and comments. I think this is an iterative process. This is the beginning of what we hope will be a long series of various different kind of topic specific events. We really want to get this right. We want this to be an exchange so that we can do things better. So any input is really gratefully received. So we'll make sure that that's passed on to you the way that you can kind of provide us with that feedback to how to make these sessions better and how to make our work alongside PPR partners better. Did James and Claire, was there anything else we needed to do in terms of housekeeping?
No, I think that's it.
Yeah.
Okay, so sorry.
I was just going to say just thank you for Colin and yourself today and everybody that's attended.
Great, so we look forward to seeing hopefully lots of you at the next session, and as I say, really want to hear your feedback about this. Thank you very much, everybody. Take care.
Thank you.